Great, thank you. It's really a pleasure to come and talk with all of you today. So I work over in Camden, New Jersey, which is a small, sad, poor city not far from here. It's right across the water in New Jersey. It's 9 square miles, 79,000 people, and the first, second, or third poorest city in the country. I spent much of my career there working in a tiny little office, which has 3 exam rooms, and I saw kids, adults, and I delivered babies. And I was very happy there. I enjoyed what I did, but I really felt like I was falling short, that the patients that I was most interested in were the sickest and the most complex patients, but that I was falling short and the healthcare system was falling short. We have an incredible healthcare system in which we routinely pull people back from the brink of death. We transplant hearts and lungs, and we should be proud of our ability to do all those things, but we don't organize people's care very well. They get overwhelmed in our healthcare system. Regardless of whether you're poor, you're middle class, or you're upper class, some of you or some of your families will have the experience of being lost and terrified in the healthcare system. So that was the problem I was seeing every day with my patients. At the same time I was seeing patients, I was having a hard time keeping my office open, that my office was beginning to go under financially. And part of that was because I was so interested in the sickest and most complex patients, but also because my payment rates kept falling. So I started out getting maybe $40 to $50, $60 a patient. By the time I closed, I was getting $19 to $35 a patient. So this is my office today. It's boarded up and closed in the city of Camden. And if zealots like me can't keep offices like this open, then that really calls into question how we construct our healthcare system. So this led me to really begin asking questions about where the money goes in healthcare. And if I couldn't pay my bills, where is the money going? Because at the same time that my office was going under, we were building new wings on hospitals in Camden. We were tripling the size of the emergency room. We were buying gamma knives, buying CAT scanners, hiring specialists. So there clearly was money in healthcare. And in fact, it's almost 20% of our economy, healthcare. We spend twice as much in America as every other industrialized country. So I knew there was money in the system. There just wasn't money in my office to be able to keep my office open. That led me over the course of time to begin to collect data from the 3 local hospitals in Camden and put it into a database and start to figure out where is the money in healthcare. So we managed to get the name, address, date of birth, date of admission, charges, receipts, and insurance status for every Camden resident from Cooper, Lourdes, and Virtua. And people don't leave the city, so this is a very good data set to be able to understand where's the money. And let me show you what I learned. We learned that half the population of Camden goes to an emergency room or hospital in a single year, that this is mostly your money. This is the taxpayers' money. Because the city is so poor, this is mostly publicly funded service. So someone went 324 times in 5 years. A single person went 113 times in 1 year. As we've learned around the country, there are people who've gone extraordinary numbers of times to hospitals. Up in the city of Trenton, someone went 450 times in a single year. You all, through your taxes, paid $108 million a year for a city of 79,000 people to go over and over to the local emergency rooms and hospitals. It's been a great economic revitalization plan for the city of Camden, so I want to thank all of you for the money you've spent. The most expensive patient was $3.5 million, single patient. 30% of the costs go to 1% of the patients, 80% to 13% of the patients, and 90% of the cost to 20% of the patients. It turns out that basic rule is true everywhere. Even if you look at middle-class people, if you look at an employee group, everywhere you look, a small sliver of people are actually driving much of the cost in healthcare. And the question you all should ask is, are you getting your money's worth? If you were a patient, did you get your money's worth? And as a society, are we getting our money's worth? And it turns out that we're failing because we ignore outliers. And outliers are people who are way out on a long curve of data, who have complex medical issues, who we simply ignore. The average physician in America has about 2,500 patients as a primary care provider, and each week, probably only 5 people are admitted and discharged from the hospital that are part of their practice. But we ignore those patients. We run from room to room to room treating head colds instead of focusing on the 5 people who were terrified, sitting at home, confused, overwhelmed, had all their meds changed, and are calling, sitting on the phone line, trying to get through the office and get appointments. Then we run into the room and run out in 15 minutes. Because that's how we've constructed the American healthcare system. It doesn't have to be that way. The number one reason to go to an emergency room in Camden, New Jersey is head colds. There were 12,000 visits for head colds over a 5-year period. Number 2 is ear infection. Number 3 is viral infection. Number 4 is sore throat. Number 5 is asthma. Most of those people have insurance cards. Those are mostly poor moms and kids. And the emergency rooms are actually making a fair amount of money on this. That's why the emergency rooms are growing larger in America. This is profitable. Most emergency room utilization is not driven by uninsured people. I want to share a very specific example of the kind of things that we see. This is a 52-year-old woman. She's Spanish-speaking, and she was admitted for inability to breathe. She lives with her family in Camden. This is a real patient. In 6 months, she got readmitted to the local hospital 6 times. She lives on a ventilator. She has a hole in her neck, and she has severe lung disease. During the time that we worked with her, each of these red lines is a trip to the hospital. On the left side of the graph is all the time that my teams worked with her. In 1 year, she had $745,000 in bills sent by the hospitals and $95,000 in payment from you, the taxpayers, for her care. Just for the hospital portion of the care. This is time along the bottom. She was in the hospital for 6 days, then 4 days, then 7 days, then she was back for 10 days, out for a couple of days, back for 11 days, over and over and over. So one of the things that I do now that my office is boarded up and closed is I run a nonprofit in the city to figure out how to care for these people better, using a mix of data, coalition building, engagement, policy change, and also outreach teams that go out and find these patients and work with them. And what we found over and over are people just like this patient, Lillian, who don't want to be in the hospital. They're overwhelmed and terrified. We're spending lots and lots of money, but we're really ignoring them. So living on a ventilator is not an easy thing to do. Her family was terrified of the ventilator. And through getting lots of training about how to manage the ventilator and getting the pulmonologist and the primary care doc to play nice and work together as a team, we were able to keep her out. And these repeatedly, all over the country, are the kinds of stories that we've begun to find. So we have the best healthcare system in America until you get really, really sick, and then you get lost in that healthcare system. So why is saving money so hard, and why is this work so difficult? It's a blockbuster video moment for the healthcare industry. This is an existential crisis to the healthcare industry. Because if every American who was really sick, every one of your family members who was really sick, got great care, we would probably cut in half the number of hospital beds that we have. So the revitalization of Philadelphia has largely been based on universities and hospitals. We don't need 4 academic health centers in Philadelphia. When you pay your tax bill to Philadelphia, when you have your contribution taken out of your check for your benefits, we have really expensive healthcare in Philadelphia because we have too much of the wrong kind of healthcare. We have too many hospitals and not enough community-based services. So these same things are impacting healthcare all over the country. And if we did the right thing, if we woke up in the morning, if we saved money in healthcare and delivered your mom, your grandparents, your aunts and uncles great care, we would cause a financial crisis in Philadelphia. We would cause a financial crisis around the country. Almost 20% of our economy is healthcare. That's a lot of jobs tied to that. So, there had to have been a moment at Blockbuster Video when a young executive came to the leadership team and said, you won't believe it. People are renting videos online and they're waiting for the videos to come in the mail. And the leadership team said, no. We've been doing this for years. We have these stores. People come to the store. They look at the videos. They argue with their spouse. They can't agree, and they walk out with a whole stack of videos, and then they return them late, and we charge them extra. It's a great business model. We're going to just keep doing this. And they've collapsed, and it's a penny stock. They're bankrupt, and they're closed up all over the country. This is where the American healthcare system is headed. If we don't make deep and fundamental shifts in how we deliver care, we have this freight train filled with 85 million baby boomers, the largest demographic bubble in the world that anyone's ever seen. 10,000 people turn 65 every day. We can't afford to deliver the disorganized care that we currently deliver to all of those people. The other reason that this is so hard is that we actually don't have a good conception of why people go to the hospital and what leads them to get sick. And one of the most profound findings in our work and in the work of people around the country is work that someone else had discovered that we had to rediscover. This is from a paper 15 years ago that no one in the medical world knows about. And it was a very simple study where a physician in California at a huge healthcare system was an obesity researcher. And he began to realize that when he worked with patients, he could get them to lose weight, but that women in particular would lose a whole lot of weight and then gain it back, and he couldn't figure out why. And he started to realize that the women that were gaining the weight back had had sexual abuse, and that as they began to lose weight, they got unwanted attention and gained the weight back. That led him to create a survey called the Adverse Childhood Experience Survey, which are a set of 10 questions that ask you about the horrible things that happen to kids from 0 to 5. About death of a parent, physical abuse, sexual abuse, one parent hitting another, a whole variety of things. And he sent it out, he had the audacity to send it out to 17,000 middle-class people. And 70% of them returned the survey. Can you imagine returning a survey like that? And they agreed to have it connected to their medical records at Kaiser Permanente, a huge medical record system. And to this day, the number of categories of adverse events is the best predictor we found for medical spending, for medical utilization, healthcare utilization, for obesity rates, for substance abuse, for smoking, for alcohol, for out-of-wedlock teen birth, for poorly controlled chronic illness, for IV drug use, for a whole variety of things. So that's really causing a shift in certain circles, but that idea has not permeated the healthcare. You know, hospitals in America are essentially filled with very damaged people who had horrible things happen to them in childhood. That's not true for everyone, but the folks that are going back over and over and over. Certainly the patients that we're caring for and all over the country that similar programs are finding have similar challenges in their history. This fact is utterly not known in the medical community, and they want to go running out of the room when I talk about it. So we have a long way to go. So I want to close by describing, the essence of our work is this idea of hotspotting. And it was really an idea taken from Bratton's work in the New York City Police Department. And Bratton realized that you had this expensive resource, the police department, and that a small number of people in the community were committing most of the crimes and were actually the victims of a lot of the crimes. And that the police department was not using themselves strategically as a resource. So he began to use data, mapping, real-time flows of data, and then he restructured the entire management of the police department to respond day by day, week by week to the needs of outliers. In a typical classroom in a school, a couple of kids have differential learning styles and don't fit into that school or that classroom. There'll be a couple of families that are down in the principal's office because those families have differential needs. Within healthcare, we've got a group of people who have unique, special, and different needs, and we're ignoring them. And we have to borrow lessons that have come out of other fields to better target our resources and to make sure that we're doing great care for everyone every day. So thank you very much for the chance to talk with you.